Welcome everyone to our congressional briefing titled The Real World Impact of NIMH Research, hosted by the Friends of NIMH and the Congressional Mental Health and Neuroscience Caucus. The Friends of NIMH is a coalition of nearly 40 mental health organizations across the country, and we're dedicated to supporting the mission of the National Institute of Mental Health. We hope that our work transforms the understanding of mental health and the treatment of mental illness through basic biomedical, behavioral, and clinical research. And ultimately, we're seeking to best inform prevention, early intervention, recovery, and cures for mental illness. I want to thank the Congressional Neuroscience and Mental Health Caucus for their support and turn our attention to some opening remarks by Congressmember Blumenauer and Luttrell.
I want to thank the Friends of NIMH for putting on this briefing today. I'm glad the Neuroscience Caucus and the Mental Health Caucus were able to collaborate with you in highlighting the work of the National Institute of Mental Health and the importance of research. It's no secret that we are facing a mental health crisis, and the pandemic made an existing problem much worse. 1 in 5 adults in the United States lives with mental illness, and 731,000 adults in my home state of Oregon have a mental health condition. Nearly half of all adolescents faced mental health challenges, and this has been made worse in the aftermath of the pandemic. Suicide is the second leading cause of death for youth and young adults, both nationally and in Oregon. It's deeply troubling that the suicide rates in this age group increased over 50% between 2000 and 2021. This must be a priority, and we must consider it from every angle. When we talk about improving mental health, we understandably consider things like workforce challenges, access to services, the criminal justice system, and wraparound services. These are all important, but we must remember to prioritize investments in mental health research. The National Institute of Mental Health is the lead federal agency on mental health research and supports more than 3,000 grants and contracts each year. This work addresses the neuroscience and brain mechanisms related to mental health, the trajectory of mental illness across the lifespan, and prevention and cures. This research is needed to help inform clinical practice and care delivery to better support our patients. I firmly believe that we need to make the careful investments and see progress and breakthroughs in how we address mental illness, or risk spending more money on worse outcomes down the road. Investing in research can yield transformative results that allow us to be a society that better prevents and treats mental health conditions. I'm looking forward to hearing from our speakers about how their work and Congress can support them. Thank you.
Hey everybody, I'm Congressman Morgan Luttrell, and I am a part of the Congressional Neuroscience Caucus. And I wanted to give you a little bit of information on why research in the traumatic brain injury space, and the post-traumatic stress space, and just brain science in general is so important. Our brains, this gelatinous substance between our ears, is so amazing. It contemplates thought. It contemplates the contemplation of thought. It put a man on the moon, put people underwater. But we don't know how this thing works. We have no idea, if you break it down, how this substance between our ears does all these amazing things. So we have to conduct research. And one of the important things in my studies is separating traumatic brain injury and post-traumatic stress, because they're two very different things. So we have to do these studies in order to find answers to the problems that we face every single day. Because right now, all we have is the ability to increase quality of life and decrease symptomatic issues. So we study, and we study. And one day, when we figure out how this thing works, who knows what the future holds. All right, God bless, and have a great day.
Welcome back. And we may not be able to get the chat function started. So if that's the case, it's okay. If you have any questions, you can make sure to include them in the Q&A box, and we'll absolutely make sure to get that into our discussion. I am going to kick us off. Hi, everyone. My name is Teresa Nguyen. I am the Chief Research Officer at Mental Health America. I am a person who lives with depression and complex PTSD, and this lens really impacts my work in research on how we can help youth who turn to the internet, who are looking for mental health support, often for the first time. As part of that, I'm excited to be here and share this panel with you today. Our first speaker is Dr. Joshua Gordon, who is the director of the National Institute of Mental Health, which is the lead federal agency for research on mental health disorders. He oversees our extensive research portfolio of basic and clinical research that seeks to transform the understanding of treatment of mental illnesses, and is really paving the way for prevention and recovery and a cure. Dr. Gordon also has extensive experience in psychiatry and neuroscience, focusing specifically on how our brains learn, grow, and heal. And just thrilled that he brings this history to his leadership at the NIMH. Our second speaker is Dr. Rebecca Price. Dr. Price is an associate professor in the departments of psychiatry and psychology at the University of Pittsburgh. Dr. Price's research is dedicated to pushing the field of cognitive neuroscience towards a more direct clinical impact. Her research focuses on the brain and mood disorders like depression, anxiety, and suicide, and how to leverage technology and new treatments to reach people who experience some of our most difficult mental health challenges. Our third speaker is Dr. David Moore. Dr. Moore is a professor of preventative medicine and chief of behavioral medicine in Northwestern University's Feinberg School of Medicine and the departments of psychiatry and medical social science. Dr. Moore's research focuses on the design, evaluation, and implementation of digital mental health technologies and services, and how technology can reach people at the earliest stages of finding out that they have a mental health condition. And last but not least, our final speaker is Eden Shavit. Eden's early career spanned roles in youth peer support, participatory evaluation, and computational public health research. Eden holds an MS in health informatics and analytics from Tufts University School of Medicine and is currently a bridge to PhD scholar at Columbia University in the Department of Computer Science. Super cool. Eden brings her lived experience in youth serving mental health systems as an advisor, and now the Research and Evaluation Subcommittee Chair for the Youth Best Practices Committee at Youth Move National. What a wonderful panel. I love the diversity of the voices that we have here, and I'm going to turn it to Dr. Gordon, who's going to kick us off.
Well, thank you very much, Teresa, for the introduction. Thank you to the Friends of NIMH for organizing this, to both the Neuroscience and Mental Health Caucuses for their support of NIMH and for helping organize this. And thanks to each of the speakers who are going to be hearing from later. My job is to set the stage for this day, and I'll try to do so briefly enough that you can get to the main events, which is these wonderful scientists and advocates and peer supports that you're going to hear from in the rest of the program. So as you've heard, NIMH is, as one of the 27 institutes and centers and make up the National Institutes of Health, responsible for conducting research in mental illness and neuroscience, and both from a basic and clinical perspective, and to ensure that the results of those research have impact on public mental health. And we're going to be focusing on that last part for this for today's session, for today's panel. We're here to talk about the real world impact of the research that NIMH supports. Many of the life-saving interventions that mental health providers and patients rely upon are the direct result of NIMH research over the past 75 years. These include antidepressants, mood-stabilizing medications, psychotherapies like dialectical behavioral therapy, treatments for autism like applied behavioral analyses, and more that you'll hear about today, both from me and from the other speakers. We're focusing on the returns of these investments in NIMH-supported research so that you, who have been our supporters all along, can understand and appreciate and help communicate that we're not just scientists sitting alone in our labs trying to answer questions that we're interested in. We are committed groups of scientists collaborating with individuals with lived experience, collaborating with healthcare providers to ensure that our work makes a difference in the lives of people suffering the burdens of mental illnesses, as well as their families and communities. What about that burden? Let's start there. You all know that mental illnesses are a tremendous burden, and as was mentioned by Senator Blumenauer, we're in a crisis, a mental health crisis right now. In the U.S., nearly 1 in 5 adults lives with a mental illness. People with serious mental illnesses carry tremendous burdens, whether we're talking about the disabilities that they cause, and or the fact that individuals with serious mental illness die younger than the general population. The societal burden of these disorders is tremendous. Collectively, mental health and substance use disorders are the 3rd leading cause of disability in the United States. Major depression as a single diagnosis is the leading cause of disability worldwide. So these are tremendously disabling illnesses. And of course, as you know, rise in suicide amongst our youth and any number of other factors are indicators that we are in a crisis. Accordingly, we in the federal government and at NIMH are trying to respond to this crisis in as responsible, proactive, and urgent manner as possible. You've heard over the last 2 State of the Union addresses that the President Biden and others in the White House have put mental health at the top of the priorities, at the center of the unity agenda. The White House has also issued a report on mental health research priorities that respond to this crisis. And accordingly, the president's budget request for NIMH has asked for a $200 million increase to our budget, which would be about a 10% increase in our budget, with specific targets: $20 million to study the mental health impacts of social media, $50 million for precision psychiatry, an additional $130 million to support better diagnostics, improve treatment, enhance precision, and importantly, make changes in the way that our healthcare system works. And you're going to hear about research today that has the potential to really address many of these concerns raised in the Unity Agenda in the White House report on mental health research priorities, and that would be funded by these increases in dollars. I want to, before I get into the research of today, though, I do want to mention a few of the many real world public health impacts that NIMH research has resulted in. And I'll go ahead and start with some of the more recent developments. So for example, in 2019, for the first time in a long time, the Food and Drug Administration approved 2 antidepressants. That's not novel, that happens all the time, but these 2 antidepressants were of 2 completely novel mechanisms, again, for the first time in a long time. And they targeted segments of the population that we've had a tremendous difficulty reaching with existing treatments. Brexanolone, a drug that was approved for postpartum depression, and esketamine, a drug that was approved for treatment-resistant depression, both resulted from decades of NIMH-sponsored research in basic neuroscience, trying to understand the fundamental mechanisms by which neurons use to communicate with each other, as well as in applied translational science, trying to understand how those mechanisms are disrupted in models of mental illness as well as individuals with depression, and then in clinical sciences, applying what we know from translational work to develop these novel treatments. And so those are 2 examples, very recent examples of the successes and the impact that NIMH research has had. In suicide prevention, although we still have a tremendous challenge with suicide deaths in the United States, NIMH research has resulted in developments like the knowledge that universal screening in healthcare settings can identify 3 times as many people who might be at risk for death by suicide and reduce their risk by up to 30% with some very simple follow-up interventions. And that work is being implemented even now, preventing even worse rises in suicide prevention in the context of the COVID pandemic. NIMH-funded research has also targeted youth, developing, as you'll hear today, novel digital technologies that have the potential to reach youth, which in ways that would otherwise be challenging because of access issues and other things. I want to talk now specifically to the two topics that you'll hear about today. One, the RAPID program, or Rapidly Acting Treatments for Treatment-Resistant Depression program, and the other, the Alacrity, or Advanced Laboratories for Accelerating the Reach and Impact of Treatments for Youth and Adults with Mental Illness. These are two programs that themselves build upon successes in the NIMH has had in the past, and try to extend those successes in the real world. Let's start with RAPID, because Dr. Price is going to be talking first. RAPID is a long-lasting program that we initiated in 2011 at NIMH that supports the development of speedier therapies for depression, in particular for treatment-resistant depression. So as many of you know, because you know people or were yourselves affected by mental illness, the treatments that we have today tend to take long time to work. We're talking weeks at best. And we really need to give people relief sooner. We need to prevent the many tragedies that happen because of the burden of mental illnesses. And one of the ways that we can do that is by making sure that we develop treatments that work more quickly. With the recognition that intravenous ketamine can help rapidly reverse the symptoms of depression and even suicidality, the NIMH has been supporting a number of different activities to develop other fast-acting antidepressants, and importantly, to build upon ketamine's success. One of what you'll hear about today is one of the more recent aspects of the RAPID program. But of course, S-ketamine was a direct result of the RAPID program in terms of moving from ketamine into other additional drugs, in this case, a racemic or a specific chemical form of ketamine that can be given intranasally instead of intravenously. So we have a number of different programs that we've worked on in terms of enhancing the availability of these rapid agents. But a big problem is, how do we get these rapid acting agents to be effectively utilized in real world settings? And suicide prevention is one area where they have tremendous promise. Ketamine is a drug that not only helps individuals quickly reduce their symptoms of depression, but within hours can reduce suicidality. And yet, we don't know how to use ketamine in an effective way, say in emergency room settings or in private doctor's offices, to take someone who comes in with acute suicidality who might otherwise need perhaps hospitalization or at least advanced care, and stabilize them enough that they can be treated as an outpatient. And so we extended the RAPID program to fund research like Dr. Price's that is figuring out how to use ketamine in real world settings to help individuals with suicidality and other symptoms of depression. The second topic you're going to hear about today comes out of one of our Alacrity centers, these advanced laboratories for accelerating the reach and impact of treatments for youth and adults with mental illness. This is the Alacrity Center program was born about 5 years ago out of the recognition that technologies and novel approaches to treatment offer tremendously exciting ways to help improve the delivery of mental health care and respond to the mental health crisis we're experiencing. But in order to take advantage of that, we need concerted efforts in implementation science, and we need multidisciplinary efforts. We need to bring together the best psychiatrists, the best technologists, and a range of different expertises in order to learn how to implement these novel approaches in, again, real world settings. And so the Alacrity Research Center program was born. It supports innovative research ideas and collaborations across disciplines to transform the care of children, adolescents, and adults with serious mental illnesses. NIMH is supporting 14 of those research centers across the country. In addition, of course, to the one you're going to hear from today, I just want to mention 2 others so that you get a sense of the breadth of the program. One such center is the Center to Accelerate Translation of Interventions to Decrease Premature Mortality in Serious Mental Illnesses. This center aims to adapt evidence-based approaches to cardiovascular disease reduction strategies, including smoking cessation, weight loss, and other approaches, which plague individuals with serious mental illness and are a huge part of the reason why their lifespan is so much reduced compared to the general population. A second center, the Laboratory for Early Psychosis Research, is developing collaborations, data systems, and methods to better understand the unique characteristics of individuals experiencing their first episode of psychosis in order to improve outcomes and develop and implement treatments that will sustain success from our early psychosis research programs like RAISE, which are now guiding coordinated specialty care and effective and implementable treatment at over 300 centers, treating thousands of people throughout the United States, again, thanks to the support of the Congressional Neuroscience and Mental Health Caucus. So these are just two of the many programs we have. Be happy to answer questions at the end about any additional ones, and including if you have questions about details about the president's proposed budget and what we might do with those dollars. But first, I want you to hear from individuals who are living this day to day, whether it be lived experience or the science. And so I'm going to turn it over to Dr. Price, who's going to tell us about her research and that of the people that she works with.
Thank you, Dr. Gordon. Good afternoon. And thank you to all who are tuning in. I'm Becca Price, and I'm a clinical psychologist and a researcher at the University of Pittsburgh. And I want to highlight right off the bat that my work has been supported consistently by NIMH throughout my career. So I just want to express my truly profound gratitude for this privilege that's entrusted to me of doing this work. So you've already heard a lot today about the devastating scope of mental health problems in our country and globally. The focus of my research in particular is on anxiety and depression and suicidality. These are the most prevalent mental health disorders worldwide. And the truth is these disorders are so prevalent that I'm certain every single one of us on this call today knows not just one, but many people who will struggle with these conditions, sometimes in silence. And this is happening right in our own families, within our friends, neighbors, and colleagues, the young people in our lives. So far too many of those we know and love are struggling under the crippling weight of these conditions. And I want to be very clear, there are numerous effective treatments available for depression and anxiety. These include both medications and psychotherapy and other options. But we certainly have room for improvement, and Dr. Gordon did a very eloquent job of highlighting some of these. So one of the problems is that our treatments tend to take weeks to months to work, so we cannot address urgent clinical needs like a suicidal crisis, and patients are left left vulnerable while they're waiting for a therapy to kick in. This is compounded by the fact that we often will require multiple attempts to find an effective option for a particular individual through trial and error. And we have a demand for mental health care that far outpaces the supply currently, because our treatments usually require expert administration. So it's very challenging to roll them out into settings where healthcare workers are stretched thin. And finally, we have upwards of 30 to 50% of patients who will ultimately be labeled as treatment resistant because they tried one or more evidence-based treatments, gave it a fair shot, and it didn't help them. So I set for myself some goals within my own research program to improve upon the status quo and try to develop new paradigms in depression and anxiety treatment. So this should be something that has a rapid therapeutic onset within hours, and also that is efficient and requires a limited investment of time from both patients and from providers. It shouldn't be something very resource intensive to deliver because our experts are already stretched far too thin when it comes to mental health care. And it should nevertheless have an enduring effect because we're trying to help chart a new trajectory for someone's life. And finally, ideally, it should be effective even for treatment-resistant patients. So this is a pretty tall order. But I did have a leg up at the start of my career because back when I was a graduate student, researchers were already discovering that the low doses of intravenous ketamine had these rapid-acting antidepressant effects, as Dr. Gordon mentioned. And so this gave this brand new potential within psychiatry to be able to bring relief within the space of a day and address urgent needs like suicidality. And this was all for a medication already in wide use within medical settings across the globe. Ketamine is on the WHO's list of essential medicines because of its favorable safety profile in the context of anesthesia. So cleverer people than me have called this the most important breakthrough in antidepressant treatment in decades, according to Dr. Gordon's predecessor at NIMH, Tom Insel. Or maybe even the greatest breakthrough in half a century, according to my collaborator, Ron Duman. And of course, the most important authority figure of all, my mom, text messaged me in 2019 when she saw on the news, as Dr. Gordon mentioned, that ketamine would be available in March as the first new antidepressant in 30 years, which I'm not vouching for the full accuracy of that statement, but it illustrates the enthusiasm for this penetrating down even to people watching the nightly news, because people in the real world really understand what a strong need there is for something new and different. So here are just some of the findings from one of the earliest studies, which was actually conducted at NIMH's intramural research program with Dr. Carlos Cerati and colleagues. And what I'm showing here is just this remarkable response rate just one day after a single infusion of ketamine, upwards of 70% of patients feeling substantially better, even in very highly treatment-resistant patients. And this compares favorably to what you would expect from a full 8 weeks of a conventional antidepressant like an SSRI. So this was and remains very exciting as a breakthrough, but a key question that still remains to this day is how do we keep that relief going? Ideally without relying solely on repeated ketamine infusions, because you can see here in this curve on the left, although depression comes down very quickly within a day, it also starts to come back up if just a single infusion has been given, and frequent repeated infusions are burdensome and costly for patients in the healthcare system. To answer that question of how to keep ketamine's impact going longer, we turn to the neuroscience literature, which has suggested that ketamine works by enhancing something called neuroplasticity, which is just the brain's capacity to flexibly adjust and reorganize itself in response to a changing environment. So the neural processes involved in neuroplasticity are incredibly complex, but at a conceptual level, this is actually pretty intuitive. We can think of a healthy brain as being one with the right number of points of contact between neurons or nodes in the brain. And you see this illustrated in this cartoon up in the upper left. And then we have evidence that in a condition like depression, you might see a withering away of some of those points of contact. So down on the bottom left, what you want to do perhaps during treatment is proliferate points of contact within key circuits of the brain so that you can arrive at a recovered brain where the most essential circuits or pathways to promoting adaptive and flexible functioning can be retained. And so let me just tell you what this boils down to me as a psychologist and for my patients sitting in the room. It comes down to a feeling that there are options and flexibility, because when we're depressed, we can get stuck into ruts, such as the rut that tells us over and over again, I'm worthless, I'm no good. So what if ketamine opens up a window of malleability in the way we think about our lives and even ourselves? And this is what we kind of drew from the neuroscience findings, suggesting this burst of neuroplasticity after ketamine. So if we're thinking about this in terms of pathways or roads in the brain, over on the left, you have a brain where there just isn't a route that gets you from A to B, such as from thinking about me, myself, to any sort of positive attribute. And so the middle piece is what ketamine can rapidly restore. It can drop in new bits and pieces of road that weren't there just a day before. And so maybe this is actually a window of opportunity to simply practice driving pathways that we think would be most therapeutic and antithetical to depression. So that, for example, those that are associated with self-worth and positive self-regard. So that on the right, you arrive at your new rerouted GPS map to keep you safe from depression going forward. And so this is what we tested in one of my studies funded by NIMH. And let me show you the techniques we came up with to practice driving those roads, because it's actually shockingly simple. So if anybody remembers Pavlov's dogs, they heard a bell, they got food. They heard a bell, they got food. And through that repetition, they're associating bell with food. So we wanted to use that really basic building block of learning to try to rehabilitate self-worth for our patients. And so we did this with certain computer tasks where we simply flash the letter I to stand in for myself. And this could be shown very, very briefly, as well as a little bit longer for half a second. And then immediately it's paired with or followed by a positive attribute like the word good. And we can do this, repeat this hundreds of times within the space of 5 or 10 minutes. We also did a picture-based version as well. So people had photos taken who are in the study. And then their photo was shown in one of 4 quadrants, and they just click on the photo, but every time they click on their own photo, it's replaced in that same location by a smiling face from a standardized set. So we're just trying to repeatedly associate self and good. So in our study, where we first tested this technique, we had 154 adult patients with treatment-resistant depression. And right here at the start of the study, they got a single infusion of ketamine or just saline, plain old salt water. So the blue line, they got saline. So you see, again, this rapid drop in depression that we've seen time and again. These 2 lines here both got ketamine. Then one day later, we started our new digital exercises. And let me just emphasize how brief this truly is. We gave the exercises for 4 days only, back to back, and each day of it takes a total of about 30 minutes to complete. So all told, we're talking about 2 hours total of a patient's time following one single administration of a medication. And then we gave no further intervention and just watched what happened with depression symptoms over time. And so what you can see in the gray line, these are folks who got a ketamine infusion followed by a sham or fake version of our computer test where there was no therapeutic content to it. And you can see what we typically see, which is a return of depression symptoms coming back up over the course of the next several weeks. But the orange line stayed more stably lower. So it stayed more as a flat line compared to where they, compared to the group that got the placebo, the saline. And so we kept following these patients to see how long this might last. And in the end, the benefits endured for 3 full months, which is roughly a 9-fold increased durability relative to when ketamine was given without the computer exercises. So this was encouraging to see that we could give this minimalistic, highly efficient digital training and see an effect of 1 single dose of a medication extend for this long. So returning to our scorecard of goals, it seems we have a promising approach that checks all of these boxes. So far, so good, but our work's far from over. It's imperative that we keep going because there's so much more that we need to do. 3 months is a great start, but that's not good enough. We need to learn how we can extend this effect much longer through perhaps intermittent infusions of ketamine or booster bursts of the digital training component. As Dr. Gordon highlighted, it's imperative to test this in populations who have an urgent need and potentially use this efficient approach within a critical window where we have access to patients. So while they're in an inpatient stay following a suicide attempt, we are testing this strategy. And in general, we would like to leverage other digital and other neuroscience-based techniques to try to create more custom fits for many other forms of psychological suffering. So I want to thank all of my collaborators, my research participants. I always like to thank my mom and my family. And then down here, I want to highlight this photo, which was taken at the award ceremony for an NIMH award known as the Biobehavioral Research Awards for Innovative New Scientists. So the brains are one, which I was deeply honored and humbled to receive and supported this study that I described today. This grant is designed to give early career investigators the ability to ask our biggest and boldest questions at an early point in our career and to give extra support for our professional development and growth as scientists. So the value of this type of support from NIMH for those of us trying to build an entire career of meaningful contributions to mental health care just can't be overstated. So thank you again.
All right. So I'll go on with the next presentation here on digital mental health services. And so what I'll do, all of the work that I'm going to be talking about is also primarily in the area of depression and anxiety. So what I'll do is talk a little bit about talk a little bit more about the problem we're trying to solve with digital mental health, tell you a little bit about what digital mental health is, and then a background on digital mental health research, NIMH's role, and then next steps, which is a little bit of a call for action. So to extend a little bit what Dr. Gordon was talking about, so there are maybe 171 million Americans and adults and adolescents, with the remaining being kids under the age of 11. And as he said, around 20% are going to have in any given year a diagnosable mental health problem. I'll also say many people will have subthreshold symptoms that could benefit from treatment. But of those 20%, only 45% receive some form of treatment, and 55% received no treatment at all. And of those who received treatment, half of that treatment might be adequate, but the other half of the people are receiving inadequate treatment. That's treatment that doesn't reach sort of minimal guidelines for quality, for what's recommended. So that leaves 41 million Americans, 3/4 of people with diagnosable mental health problems who are receiving no treatment or subpar treatment. Now, part of the problem here is that we don't have enough mental health providers. So SAMHSA estimates that by 2025, we will have a shortage of around 125,000 mental health service providers. We're going to be short 15,000 psychiatrists, 57,000 psychologists, 27,000 mental health counselors, 15,000 social workers, 10,000 marriage and family therapists. So we don't have enough mental health providers. And of those who we do have, they are not distributed equally. So most mental health providers live in urban areas, leaving 130 million Americans in what are federally designated mental health professional shortage areas. So digital mental health, holds promise to be able to overcome some of these challenges. So what is digital mental health? Well, it's using available technologies like apps, or currently the main ones are apps or internet sites, to deliver or manage mental health treatment. And the way in which it does that is to they try to support and teach evidence-based self-management strategies. So there are around 90, depending on the taxonomy you look at, around 90 different evidence-based strategies. These are little things that people can do that are going to improve their symptoms. Like behavioral activation is, increasing your activities that are pleasurable or bring a sense of accomplishment. Cognitive restructuring is being able to identify negative thinking patterns and change them. There's goal setting, physical activity, mindfulness. All of these things, if people do it, it increases the likelihood that they're going to start feeling better. So digital mental health treatments can also be delivered in a number of different ways. So one way is fully automated. That's just like getting an app off of the app stores, right? You can pull it down, you can look at it and use it as you like. Another is coached. So taking those digital tools and having some human support on the back end to try to help people stay engaged and get the most out of it. And then the third is adjunctive. So using the tools as part of psychotherapy or part of pharmacotherapy to help people, for example, stay adherent to their medications. So what does the science tell us about this? Well, for fully automated, like just pulling down an app from the app stores, what we see is an abandonment rate of about 96% within the first 2 weeks. And most of that is in the first few days. And as several people have mentioned so far, for psychological and behavioral treatments, people have to stay engaged for at least 4 to 6 weeks to even begin to see some benefit. So the vast majority of these, of people who are just using an app, it's not going to provide benefit. For the few who do, it does, but for the vast majority, this doesn't, the technology by itself isn't going to help. However, when you put some human support behind it, we see things change drastically. So there have been more than 70 randomized controlled trials, the gold standard in medicine and psychiatry, showing consistently that coached digital mental health treatments are effective. Now, these coaches, they can be peers, they can be non-licensed lay people. Frequently, they can be, and we've seen there's research showing that those people are just as effective, and some showing slightly more effective than licensed professionals. So this gives us the opportunity to expand the potential workforce. Coaching is generally brief and low intensity. So most studies that have used coaching, it's about an hour to 2 hours over the course of a 12 or 16 week treatment. So it doesn't take much time. It's often just staying in touch with the person via messaging to help them keep on track. And this is the evidence has shown consistently that just the presence of a human being, in that fashion helps maintain engagement with the tool, and the outcomes are just as effective as psychotherapy or pharmacotherapy. So what can digital mental health do? Well, it can extend the psychological and behavioral treatments to people who can't access it due to geography, as we saw, due to the absence of care providers in the region, due to time constraints, like a single mother who has to also hold down a job and doesn't have time to go to regular appointments, reluctance to engage in therapy. And Dr. Gordon mentioned adolescents. Adolescents place a high, and young people place a high value on self-reliance. They tend not to want to talk to somebody else. And yet we do see that they are willing and open to using digital tools, and it can reduce costs. And I'll say a little more about that in a moment. What digital mental health is not, is it is not a replacement for psychotherapy. It is not a replacement for other treatments. It is another tool in our armamentarium to be able to manage mental health. Technology does not eliminate the need for human support, but it can make people and it can make healthcare systems more efficient. So I'm going to just talk a little bit about using a few of the NIMH supported research programs that we've had in our center, give you a sense of how NIMH has established the evidence base, and it's really been critical to establishing this evidence base. So in 2008 to 2012, we had one of the first early trials of a coached digital mental health treatment that was deployed in primary care and showed the effectiveness, but also importantly, it validated what is now one of the most widely used coaching models, both in research and is also being adopted in industry. In 2011 to 17, we had a center grant that was looking at how we can begin to harness other kinds of technologies for mental health. And for example, one of the things that came out that has really spurred a lot of research is the use of sensors in our cell phones to identify depression and behaviors related to depression. So our phones now have a huge number of sensors in them: GPS, accelerometry, light sensors, and so on. And those sensors can detect pretty reliably when people go to bed, when they get up. They can detect depression. We've shown that it also can detect when somebody is at risk for worsening over the next 2 weeks, when somebody may be getting better. So NIMH has been involved in how we harness these technologies in new and innovative ways. I want to particularly highlight this next one, STEP mental health care. So we looked at, what STEP mental health care is in this case is, we start a patient with depression on a digital mental health treatment and follow them. And if we don't see evidence that they're improving, then we step them up to receive psychotherapy. And we compared that to psychotherapy alone. And what we found was that the STEP care program was just as effective as psychotherapy and produced those benefits at half the cost of psychotherapy. So it is cost effective. And then I also just want to give a shout out to Teresa, who introduced us. So we have a number of collaborations funded by the NIMH with Mental Health America. What she didn't mention is that Mental Health America has screeners up on their site, mental health screeners that are now being taken by more than 5 million people a year. And Mental Health America, I think, has the potential to really become one of the principal public mental health platforms in our country. And so we're working with them as well. To move on to the Alacrity Center, one of the things that I've appreciated in working over the years with NIMH is that NIMH is really forward-thinking. Often I have to say more forward-thinking than some of my colleagues in academia. So, NIMH recognized, a number of years ago that we have this research to practice gap. So we have lots of studies showing that digital mental health works, but it's not getting implemented. And so, our center and many of the other centers are looking at how we overcome that. And it is not easy to fit these kinds of tools and these kinds of services into existing healthcare systems. So what we're doing is looking at how we can place these services in family medicine in 3 settings. One is family medicine, one is a perinatal depression program within OBGYN, and a third is in a geriatrics program for homebound older adults. And so we're using these programs also to establish guidelines for research methods that are going to do a better job of overcoming these research to practice gaps. So now I'm going to move on to start to move into what we can do next. So there are a lot of there continues to be a big need for basic research in this area to harness technologies, to understand new ways of doing that. But we have the tools now to implement these kinds of services, and many countries around the world are doing that. Many countries have implemented reimbursement and regulatory processes for digital mental health and are beginning to integrate it into their healthcare systems. And it's not easy, but it's happening. In this country, the Banbury Center, which is a conference center that's attached to Cold Springs Harbor, a large national laboratory, and that the Banbury Center has for decades identified research to practice gaps and looked at how they can assist in overcoming them. And I think probably somebody from the NIMH, talking to them said, you should talk to David Moore and to Pat Arian at the University of Washington, and they did, and they helped us put together a forum that included stakeholders from payer systems like Optum, Magellan, care systems like Kaiser Permanente, policy people, self-insured employers, lots of the stakeholders who need to be involved to look at how we overcome this research to practice gap. And it came out with three recommendations. So the first was that there's enough evidence here that coached or guided digital mental health treatments are effective, and they should be offered to all patients experiencing depression, anxiety disorders, and post-traumatic stress disorder. The challenge is that there are no reimbursement mechanisms in the United States. So any system that requires that runs on even partially a fee-for-service model can't implement them. So there should be reimbursement mechanisms put into place, and we need an evidence standards framework so that people making decisions can know what's a good product and what isn't. So this gets to my call to action. So we are seeing the pandemic has been a huge accelerator in this area. So a lot of accountable care organizations have begun implementing it. Kaiser Permanente has put together their Kamai platform, which connects their members with last I heard it was 6 different digital mental health services. And they've had over 200,000 patients be connected with those services. Medicaid, I think it's now up to 14 states have passed legislation that allow for reimbursement in Medicaid for Medicaid in their states. And I will say that these are not red states or blue states. It is a mix. This seems to be a bipartisan issue. There's legislation that was introduced for a second time in March of this year, the Access to Prescription Digital Therapeutics Act. It's been introduced to the House and to the Senate. And so it would establish new Medicare and Medicaid benefit categories for prescription digital therapeutics that would essentially allow for the mechanisms for reimbursement to occur. And once that happens, insurance providers will very likely follow. And a digital therapeutic in this case is very much like a digital mental health tool, but it covers also, medical problems like diabetes or heart disease. So it covers the gamut. The one thing, if there are people here who are interested in this, and I'm happy to talk with them, but there are some issues in this bill specifically for mental health that are a problem. So it is defined as a prescription benefit, which means that somebody who has prescribing privileges has to prescribe it. In mental health, most of the care is provided by people who do not have prescription privileges. So it separates out access to the tools from most of the people who are providing the care. And that is likely to become a huge barrier because people then have to go back to their doctor. Germany has rolled out this in the same method, in the same way as a prescription benefit, and they're finding very low uptake of the mental health therapeutics because of this problem. And so the one thing that I would really urge here is that be changed to prescription or order so that people who don't necessarily, so providers, licensed providers who don't necessarily have prescription privileges can get these tools into the hands of people. But otherwise, I think this is a huge step forward. And that's that is what I had to talk about today. So I want to thank you all. Do a brief plug to our Society for Digital Mental Health, which is having an annual meeting if you're interested in learning more, and our monthly webinar, which also has experts from digital mental health speak every month. Thank you.
All right, hello everyone. It is such a pleasure to be here today. Thank you so much for having me. My name is Eden Shavit. I am a Bridge to PhD scholar in the Department of Computer Science at Columbia University and am the chair of the Research and Evaluation Subcommittee of the Youth Best Practice Committee at Youth Move National. And I am one of many people in this country with lived consumer experience in youth serving mental health systems. And that experience informs the lens from which I operate across many contexts and has shaped much of my early career. And a part of that career has been involvement in NIMH-funded projects with strong commitments to participatory models of meaningful consumer engagement, including serving in a stakeholder advisory capacity at the Center to Optimize Evidence-Based Practice Implementation for Clinical Impact, or just the Impact Center, which is an interinstitutional NIMH-funded alacrity center at the University of Washington, the Kaiser Permanente Washington Health Research Institute, and the University of Michigan. I was also a part of an integrated research team that included folks from Youth Move National and the University of Washington Smart Center for an NIMH-funded R21 under our wonderful PI, Dr. Mike Pullman, called the Ripple Effect Study. And what I'm really hoping to convey to you all today are the real-world impacts and values of meaningful consumer engagement in NIMH-funded work, using the Ripple Effect Study as a particularly strong example of how NIMH-funded research can be done in partnership with communities served, and how that just makes the work better overall. At a high level, this project was funded to do two things. The first was to identify potential unintended consequences of evidence-based practices, or EBP, implementation strategies such as training, specific supervision, integration of digital tools, what have you, and to look at the unintended consequences or ripple effects of how these strategies, in view of one co-determined construct of interest, kind of exist and impact it. And that construct of interest that we co-determined was how an implementation strategy might impact the adequacy or the appropriateness of mental health services rendered. And the second piece was to design and test and measure relative to this construct, which could be used as an evaluative tool in care quality assurance, research, and program evaluation contexts. It is particularly important that I highlight the fact that this was a participatory process from beginning to end, and that we as young people with lived experience had a really critical role to play in all aspects of the project. We regularly convened as an integrated work group that included Youth Move affiliated folks alongside research faculty and staff at the University of Washington. We co-designed items that would be used for psychometric data collection from our population of interest, which for those of us on the Youth Move side were really people like us, our near age and circumstantial peers. And during the analysis phase, we found a really great synergy between statistical and theoretical reasoning, with the UW side leading technical analyses and the Youth Move side offering interpretation of results in order to identify and distill the 10 best items for our measure. Through this project, we got to see just how vital community integration is for reliable community-oriented research, in the sense that there were circumstances where the interpretations on the Youth Move side altered how we as a group contextualized the data in front of us and impacted what we prioritized throughout the study. For example, there was a real focus on youth culture and communication styles and care contexts, and the degree to which that match impacts whether a service is perceived as appropriate by a young person receiving services, which doesn't always come up when young people aren't a part of these conversations. All this to say that youth input had a considerable impact on what construct was chosen, how the context of the information we collected was understood by the research team, how we could create a measure that would be pragmatic from the perspective of near age and circumstantial peers that would actually want to use it, and how the narrative of youth involvement was ultimately put forth in our paper. In the end, what we created was a measure that clinicians could incorporate into their practice on a regular basis that diverges from traditional approaches to measurement-based care, which is oftentimes only concerned with how consumers are functioning and leaves the clinician to guess as to whether their specific therapeutic approach is working for that particular person. So instead, what we created was a real-time co-developed feedback tool that we intend to make widely available in the near future that can help clinicians retrieve meaningful feedback about their strategies from the young people they've served in an effort to increase treatment engagement and effectiveness. Without this collaboration between UW and Youth Move, this may have been a completely different study and potentially a very different tool that wouldn't have picked up on the things that young people receiving services actually believe are important in the efficacy of their services. And an additional impact is that young people involved were shown, perhaps for the first time, that their perspectives mattered in research design and execution contexts, and that they were a valuable part of an integrated research team, not just someone being consulted to meet a participatory quota without consideration for whether that participation was actually meaningful. We know that participatory research can lead to more relevant and impactful outcomes and can help build trust between researchers and the community served, which may promote more sustainable solutions and interventions, what have you. So when this study decided to meaningfully include the voices and perspectives of young people with lived experience in the work, it wasn't just a feel-good thing to do, it was good science. But what it also did, and what many good participatory projects do, is create an opportunity to enrich our institutions of mental health research in the long term by nurturing a pathway for folks with diverse experiences in the mental health system to be exposed to and to explore their own careers in research that is informed by their unique perspectives and their questions that they themselves are uniquely situated to pose and investigate. I mentioned earlier that I'm now at Columbia in a research-oriented role in preparation for graduate school and serve in a leadership position for Youth Move's Research and Evaluation Subcommittee. These are things that wouldn't have happened without meaningfully engaging me in this kind of work for a number of years as a young person and exposing me and my peers to what research is and what it can be when done in thoughtful collaboration with others. So as a final point, I would say that my personal career development narrative is perhaps also a real-world impact of NIMH-funded research, as well as other participatory research, and that incorporating additional consumer involvement into NIMH's strategic plan would be an amazing way to keep this momentum going and make these kind of outcomes more prevalent, either by specifically funding this kind of work or giving additional emphasis to consumer involvement in regularly funded NIMH work. And I can already see that happening by way of forming and inviting people with lived experience to join Alacrity Center stakeholder advisory boards, such as the one at the Impact Center where I was recently invited to join. And with that, I will thank you very much for your time, and I'm happy to take questions.
Thank you, everyone. I think that's a perfect end to understanding what it means when we're impacted on the other side in community. And I want to offer Dr. Gordon a moment to say goodbye. Unfortunately, he has to leave us today, and give him an opportunity to say any closing thoughts that he has.
Well, I want to thank everyone for coming, and I want to thank the speakers on the panel. You heard really about some wonderful research and wonderful experiences and the impact of that research. I want to turn it over back to Teresa for questions and answers. The other panelists are going to remain, so please, if you do have time and have questions, I did try to answer one or two of them in the Q&A function while things were going on because it looked like I wasn't going to be able to answer them in person. I do have another meeting I've been called away for. So thank you very, very much, everyone, and please enjoy the Q&A session.
Thank you, Dr. Gordon. Have a great day. And I am going to kick us off by talking about anxiety and depression. So Amanda has a question about your research for both of you, or everyone here, because everyone here is involved in research. I think anxiety and depression is an easy space to start. And certainly our understanding of mental health conditions has changed. So even the bucket, or the notion of how mood and perceived threats, these are notions that have developed over time. But can you speak to how your research, I know you've started with anxiety, maybe depression or suicide, but can we speak to how your research can lead to understanding in other mental health conditions? Amanda is particularly interested in somatic or functional neurological disorders, but feel free to chime in, anyone here who can speak to, how your research, even though it starts with depression or anxiety, absolutely has implication for other other mental health challenges?
Well, I can start on the digital mental health side. I think the recommendations have been made for for digital mental health services in depression and anxiety and post-traumatic stress disorder, because that's where the most of the research has been. So there's just overwhelming evidence there that it's effective. There is a lot of research going on in more severe mental illness and bipolar disorder and schizophrenia. And it's clear that there's a lot of potential there. There have been a number of trials that have been successful. There was one that came out in JAMA Psychiatry from our center in bipolar disorder, showing that that a digital mental health service, again, not just giving people an app, but with coaching on the backside, it was particularly effective for in maintaining adherence to medications and improving functional outcomes over the course of over a year, particularly for in people who have less severe disorders. It was less effective in people with more severe disorders. So I think when we start looking at severe mental illness, you're going to start seeing these separations of different groups who are going to need different kinds of support. There have also been similar studies in Dror Ben-Zeev at the University of Washington has developed tools that have been effective in helping people with schizophrenia manage their illness. So I think that there is a lot of hope for digital mental health playing a role in SMI. It's just that the preponderance of evidence isn't there yet to make the kinds of recommendations that that you would need for guidelines. But I think they'll come.
I could just quickly add, quite similarly to what Dr. Moore said, in the realm of intravenous ketamine, the bulk of the studies have been done in depression, with some being done in bipolar depression, and then a larger number being done in unipolar depression or major depressive disorder. And then there's a literature in PTSD. But from there, it certainly is expanding into many different conditions. And, there's just a smaller evidence base, but growing across the board, from eating disorders, pretty much you name it. Somebody's probably trying to see whether this same principle would apply, of kind of increasing neuroplasticity to induce a healing effect. And I would just mention as well that the initiative that Dr. Gordon highlighted among suicide risk and trying to focus in on there, in my study in particular, but I think in many of the studies that were funded under that initiative, there's a transdiagnostic focus, so that it's not that you have to fit a narrow set of criteria for a specific disorder, but it's much more defined upon things like having a suicide attempt, which is, irrespective of a diagnosis, is going to put you at a unfortunate risk. And so we want to, really understand how can we help in that situation, and not and do it in a kind of really real world way, to understand across the kind of severity spectrum, how can we help?
Yeah. I'm a real proponent of transdiagnostic approaches. And I imagine, Eden, in your work, when you're advising, you see that people bring the fullness of their lived experience. I can't bucket myself just like as a depressed person or an anxious person, right? And that lens has impact. I don't think we come as one person with one issue.
Absolutely. Everything is so socially dependent on each other. Absolutely.
Okay, well, let's see here. I have a question for Dr. Price. Someone wants to know what the markers are for treatment-resistant depression. So what determines what kind of treatment is most effective for typical treatment versus ketamine?
So the first part of the question, how is this defined? Oftentimes in research, to my dismay as a psychologist, it's most often defined based on just medication response, in terms of having had an adequate dose for an adequate length of time of an FDA-approved antidepressant medication. Mm-hmm. So typically in the ketamine studies, there will be a requirement to enter the study to have had 1, 2, 3, and oftentimes many more of such treatment attempts that were not successful. So that's often how it's defined. But I certainly think that there's a need to acknowledge, that those aren't the only evidence-based treatments for depression. And so we need to, kind of think about treatment resistance across the board. And certainly there are individuals who also try something like cognitive behavioral therapy and give that their best shot and also don't benefit there. So understanding, how these different patient experiences might intersect and who might be most appropriate for something that's considered, not a first line option, but maybe a later option. Where does it fit in to the decision kind of algorithm clinically when it comes to ketamine or other kind of more novel agents? That's very much an open question at this point.
Yeah. Great. Thank you. There's an interesting question about schools, and this might be a hard discussion because so much of the research here is in specific clinical spaces, but Mark does talk about how the pandemic has affected our brains and affected our sense of helplessness or control. Have any of you guys in your research interacted with schools? Think about the implication of your work in schools or in specific skills with teaching people skill-based training around helplessness or control, self-efficacy, things like that.
I can speak a little bit to that. My personal work has been more in, as you mentioned, Teresa, has been more in healthcare settings, and but there are people in our center working with kids, and have a lot of colleagues working with kids. Schools are great places to deploy these kinds of interventions because schools have a lot of the infrastructure that can support it. So, for example, most kids in the United States have a semester or two of health studies where they, where increasingly stress management and sort of prevention kinds of things are taught. Schools, they're understaffed, but many schools do have some sort of counselor who is available to some degree to help kids, and so there is infrastructure there for the in schools for deployment of digital mental health tools. This is being tested more widely in other countries. So Australia, for example, has a couple of large programs where they're looking at rolling out digital mental health sort of training programs as prevention tools in high schools. So as part of the health curriculum, it gets rolled out and they interact with these things. They learn techniques, and they're looking over a long term if that can lead to to a reduction in the incidence down the road. Because we know that if we can effectively treat kids in a first emergence of a depressive episode, that we can bend the curve on the incidence of depression, that people they'll be less likely to develop depression or mental illness problems in the future. So schools, I think, are really important places where we can deploy these kinds of tools. And unfortunately, I think other countries are out ahead of us in this, but I think it's a possibility here. I also just want to take this as an opportunity to say that there's a lot of places outside of traditional healthcare systems where we can deploy these. I mentioned Mental Health America, but another one where we're looking at in our center, we have another investigator, Ashley Knapp, who is working with libraries. So libraries increasingly, many libraries, particularly in urban areas, particularly in low-income urban areas, are beginning to have functions around that include social work, that include helping people with mental health problems. Some of the libraries in the Chicagoland area have, they've started hiring social workers because that became a place where people were dropping off their kids, to make a transition to the parent where there's been a divorce, or so the libraries are getting, mixed, placed in the position of providing services. And so she's looking at how libraries can be used or how libraries can harness digital mental health tools. And you can imagine, libraries provide lots of digital content. So why couldn't digital mental health tools be part of the content that gets delivered, just like they deliver now ebooks and they deliver movies? Mental health can also be delivered that way. So I think that there are lots of areas that that we can deliver this kind of treatment outside of traditional care settings, and in particular settings that are where where kids, places where we can access kids, because the healthcare system and the mental health care system is not typically where kids get identified.
Yeah. And you speak about libraries. John was asking about whether or not the digital mental health tools are used or researched in inner cities. And so libraries and that research, I imagine a lot of that is being done with communities who are not getting access to care. I wanted to ask Eden, in your experience informing participatory research, I know community participatory research is very important that we think about who is not being served. Kind of how did you see that play out for you as advisors in the way that researchers are thinking about diverse groups and making sure these people are coming to the table?
I think that's a challenging, unsolved challenge across mental health research domains at large. But in the context of our studies, we attempt to take an interdisciplinary approach to participant recruitment, leveraging the Youth Move National Network, which is a chapter-based network that's present in nearly every state in the United States, as well as tribal territories, and leverage the breadth of expertise within our own network, as well as taking advantage of services that attempt to identify participants for survey completion. So that's a way that we addressed it in this particular study that I had mentioned. But at large, I know this is a challenge for lots of folks in this space.
Yeah, and one we really should, I imagine we're going to focus on increasingly over time, especially with additional investment, because these things aren't, it takes time and effort and money and support to communities to do research well. And it's been great to see some models of what this looks like in this panel. I think we have time for one more question, and I have one from about human and non-human research, which I think is really interesting. This one is to Dr. Price. Your research was conducted on non-human animals, but can you tell us more about how that research has informed your study on humans?
So sorry, my talk was unclear on this. My research is only done in humans.
Okay.
So yeah, all of my findings from my own research are in human patients, often with treatment-resistant depression, anxiety, OCD, suicide history, behavioral history. Yeah, the neuroscience literature in animals, oftentimes in the space of ketamine, is actually in rodent models. And so this informs our understanding of how the treatment might be working, and kind of helped inspire this idea of how can we create a synergistic fit between what ketamine might be doing in the brain and what we can do with a brief digital training. So I hope that answers the question and clarifies.
Yeah, absolutely. And I think I will just close out our session with acknowledging a member in our group talked about isolation and loneliness. I appreciate everybody here because you bring a different lens, whether we're tackling treatment-resistant depression and suicide, which is weighty and on one side of the spectrum, or digital mental health, as we explored building skills and how we can translate all of this into real world impact for people and community. And it's really exciting to see that research is doing it. Before our attendees leave today, I want to thank everyone for joining, but I also just want to give a little shout out that it is the 75th anniversary for NIMH. And actually starting on September 13th, 2023, the NIMH is hosting its inaugural 75th anniversary event, which is going to start like a year-long awesome celebration. So save the date, September 13th. And you can also subscribe to NIMH's email updates on the NIMH website or follow NIMH on social media to stay up to date about the anniversary. He's not here, and I just want to give another thanks to Dr. Gordon and also to the Friends of NIMH and our caucuses who have supported us today. Thank you so much, everyone, and we hope you have a wonderful day.